occipital condyle. All right? Now, one of the rules in the spine is that I can never reach in and grab a bone and pull it back. Can't do it. I can push a bone forward, but I can't pull it back. So, whenever a bone needs to come backwards, this is like a little principle that's not really in your manual. All the steps are in there that describe this, but this is like a principle, okay? Whenever a bone in the spine needs to come backwards, I'm going to have to push the bottom bone forward, because I can't pull this back. If the bone needs to go forward, I can push it forward. So I can get right on that bone and push it forward. Right? So if you just remember that principle, it'll serve you well through the whole spine. So when you push a bone forward, it'll always be the top bone of the joint. When you have to pull a bone back, you will always be pushing the bottom bone of the joint forward. So in all cases, you're pushing forward, because you can't pull back. So, she turned to the right. She had pain before the barrier. The indication is specific traction. Okay? Because she was able to go from here to here, but then her pain started, and when I started to passively move her, the barrier was like here. Okay? So she has pain before the barrier. The indication is specific traction. Specific traction is very gentle because it's a grade 1 movement. So the main way that you can accomplish specific traction is through clamping their head to your chest and then breathing. What happens when I breathe in? My chest goes up. When I breathe out, my chest goes down. If I've got her head clamped to my chest, as I breathe in, her head's going to go up. As I breathe out, it's going to go down. And that will be a very nice grade 1 oscillation. There is nothing that says oscillations need to be fast. They just need to be rhythmic and controlled. So, bring your chair up here and turn to the right. So, if I want to do specific traction to the AO joint, this is a bilateral technique.
And ma'am, you wouldn't have the patient in the point of pain. This would be back in neutral.
That's correct. Okay? If I want to do specific traction to either of the AO joints point, I can stand on either side because it's a bilateral technique. In other words, as I do this thing, both joints are being distracting. Okay? Now, one of the things that a couple of you were doing is that as you tried to grab the person's head, you were pulling their head in towards you like this. So you can't do that. You've got to position yourself so that the patient's head stays in neutral while you're doing whatever it is you're going to do. So don't add the side bending component. So how do I do that? I have to lean in like this. So if your chair is too high or your surface is too high, then their head will end up, for women, in your breast or down below your breast. So you don't want that. You've got to have the height of whatever it is that they're sitting on to be so that you can get their head towards this part of your chest. All right? So and to be able to do that well, if I stand like this, it's going to be harder. If I do this, it's easier because now I can actually get her head right here. All right? So I grab her like this. This is the handhold we used yesterday. I'm just going to stabilize C1. We did that yesterday. Remember that? to stabilize C1 with our grip like we did yesterday. My little finger is underneath of the occipital condyle here, so I can get some purchase. You know, I can grab the occiput. If I'm just like this, it's not going to work as well. So I've got to get my hand under the occiput. Okay? Now watch, see how my little finger and my index finger are together? Why don't you like hang out right there? Sit down or something like that. Because if you're too far away and you can't see this, come on up, okay? So that's what the way your hand should be positioned, is that your hand stabilizing C1 and your hand stabilizing the occiput, your two fingers should be touching. Now watch when I breathe. Are you able to see the distraction?
So it's your breathing and not hers.
That's correct. It's my breathing.
You exaggerate your breathing? You exaggerate your breathing?
Yeah, you just take a nice deep breath in. Okay? I've got her head really hugged to my shoulder here. Okay?
Are you stabilizing the lower hand, trying to push a little downwards when you're doing that? So
Hold
there's
it still, yes. So you've got to, it'll be a relative downward pressure. But I'm not actually, as I do this, I'm not going like that.
Right.
Okay? The key is to get a nice firm grip on C1 and hold it still. Okay? So that's specific traction. Very easy to do, very gentle. The patient will, basically what I say to them is, all it's going to feel like to you is that I'm hugging your head. You really won't be able to tell that I'm doing anything.
Why would you do that in sitting where you have gravity, the weight of the head you have to deal with, and not supine?
Because you can't effectively stabilize C1 and perform this distraction in a controlled way in C1. You can't do it. Because I'm really grabbing both sides of the head, and there's no way to really do that in supine.
I don't think so.
How long do you do this? A minute or so?
So that's a good question. How long do you do it? Usually what, and I don't know if Maitland says this or not, but what I do is I'll try to do between 25 and 30 oscillations, and then I'll take a break because I need a break. All right? After every set of reps that you do, check the range of motion. So if I just did 25 to 30 oscillations to this, I'm going to go back now and say, okay, let's see how your pain is doing now.